Good morning.
Welcome to the morning show.
Yeah.
The Big Show with Glenn and Angel on Kiss 92.
Good morning.
Sometimes getting out of bed in the morning is a lot to deal with all at once.
It is a good morning indeed, because we're so happy that Good Morning Doctor is back.
It's
now,
back.
the doctors all had to take a break, obviously, because, doctors have children too. They're
Yes.
humans.
School holidays.
So they had to take a break, go away with the family, spend some time with the family, but they are back in the house, and we'd like to say good morning to Dr. Edgar Tay, cardiologist from Mount Elizabeth Hospitals. Good morning, doctor.
Good morning, and thank you for having me.
Yeah, would you say that you are the doctor with a heart? Technically, you are the doctor with many hearts.
Yeah, how many hearts have you handled, doctor? That's an interesting one.
I'm not sure, a couple of thousands.
Couple of thousands. Wow. Okay, so let's get to know you a little bit more before we actually delve into today's topic, which is living with holes in the heart. Now, you are what they call it, interventional cardiologist, but you also trained in structural cardiology. I mean, tell us what the difference is with all these terms.
So, interventional cardiology means the cardiologist that does procedures. So, they could be, say, doing stents, opening of blockages. Structural relates really to the internal structures of the heart. So, if there is a defect in the heart, like a hole in the heart, for example, or if there's internal problems with the moving parts of the valves or structures within, then that's what my subspecialty interest is.
Almost like an architect and
Kind
an
of.
interior designer.
Wow.
Versus
Right?
the
That's
plumber.
an interesting way
Yeah.
to put it.
Okay.
Okay, so today, obviously, we're here. We're going to be talking about, living with holes in the heart. What can you do? What does it mean when someone has a hole in the heart?
Right. So to understand these structures, we have to understand a little bit of how the heart develops. So actually, when we're all fetuses, right, our heart is actually like a little, like a tube, like a balloon.
Oh.
And then somebody kind of twists as it grows. It's like twisted into a specific shape, and within these shapes, there will be these walls that will be created within the heart, and this actually separates the right and left heart, right? So these are actually important walls that separate the right side of the heart from the left.
Ventricles, right? Are they called? Is that what it's
So
called?
this could be ventricles, or at the bottom part, or the atrium.
See,
upper
I
part, yeah.
remember my secondary school biology.
So it's literally like a building.
Yeah.
Yes, so it's
Okay.
compartmentalization essentially. So whenever there is a defect in this wall, for example, like a hole that didn't develop properly, then we call that hole in the heart.
Okay,
Oh,
so
right,
it is
okay.
something that they would have from young, naturally occurring.
Yeah, so there are two types of holes that we usually tell patients. For example, just use the analogy of the upper rooms, right?
Yeah.
So this wall in the atrium. So there are types where where the fetus is growing, this wall didn't grow, and that's what we call a real congenital defect. They when they are born, there's actually a hole that you can literally see in the heart itself.
In
So
the tube.
in the wall.
In the wall,
yeah.
okay, all right.
And there's another type that is actually more like a door. And this particular door, we call it a foramen ovale, or
Yeah.
PFO for short. And this is actually an important door that allows blood to flow within the fetus, because when the fetus is being developed, right, the lungs doesn't expand, and the oxygen that needs to get to the baby is directly through the mother's blood. So this door actually allows the mother's blood to pass through. So this is a natural sort of gate or door.
Right.
Okay. So all of us have that.
Okay.
And when we are born, the minute we take a deep breath as a baby,
Yeah.
this door will close.
Oh, wow. That's so interesting.
Yeah.
Oh, my gosh.
Now, is this something that can develop over time? Like maybe you had a perfect heart, growing up, developed perfectly your heart, and then suddenly, as you got older, I mean, for whatever reason,
A hole happened.
Yes, a hole started to develop.
So usually that does not happen. Most times a person either have a defective formation, so there's actually a gap already. But the more common one is this particular door that we spoke about. It doesn't close. So in some
Got
groups
it.
of patients, these doors remain open.
Yeah.
So we call it patent. So they remain open. So 1/4 of us, maybe like out of the people here in our room, 1 or 2 of us will have this door that remains open.
Oh.
Yeah. So on its own, the ability to open this door is not a major problem for most people, but in selected individuals, that can become a problem. So they could have problems of increased risk of things like migraines. They could have increased risk of stroke in some patients. So this is actually a kind of like almost like a normal structure.
Yep.
But in 1/4 of us, this door didn't close.
So is it important to get that door closed?
So we don't routinely go and
Right,
close
okay.
this door because 1/4 of us are walking around with no problems.
Yeah.
So we close this when patients have problems.
But you say it can cause migraines and things like that, and people wouldn't necessarily think it's because of the heart.
Yeah.
But
You
it's
know?
not a. So they've tested closing some of these holes.
Yeah.
In some patients it works, but in some they don't. So it's
Right.
not consistent.
It's not a risk they want
Yes.
to take. Yeah.
And
okay.
so it's actually reserved for patients with most times stroke. So young people who have developed stroke, we always have to look for these
Open
structures,
doors.
and then we have to kind of close them.
Okay, let's continue this conversation with Dr. Tay on The Big Show TV. Join us on YouTube and Facebook at Kiss 92 FM. He's also brought in some actual equipment and little gadgets that they actually put into patients to plug the holes. So join us because you don't want to miss this. Here's Sabrina Carpenter with Espresso on Kiss 92.
Okay, just following it on what Angel just asked, right? I mean, with the things to look out for, okay? Signs and symptoms, okay? Because you also mentioned that you guys don't routinely check for something like this. But, for those of us learning about this for the very first time, I mean, are there things we should keep in mind? What are the very obvious signs and symptoms that we should be experiencing before we go, hey, maybe we should kind of get this checked out?
So there are certain high-risk individuals and occupations that we actually detect. So these are, for example, divers. So if people do diving, for example, and they get this thing called the bends, I'm not sure if you've heard
Yeah, yeah,
pain
yeah.
and all that,
Yeah.
right? Or some even have tingling and all that, or some neurological signs. Those are patients that you think about. Perhaps they might have a PFO because the bubbles actually bubbles that form within the blood crosses this one, they feel symptoms. Or patients who are doing a lot of gymming, for example, and they strain really hard at certain weight lift maneuvers, and then suddenly they feel like numbness or weakness.
Oh, wow.
Those usually would mean, because straining opens the door, and if there was a small little particle like a speck of clot or somewhere and
Yeah.
it travels through, then they get what is called minor symptom or minor stroke. So these are kind of warning signs
Okay.
that sometimes we detect as well. But of course, the most serious type
Yep.
would be a big clot that travels through and the patient gets paralyzed.
Oh, dear.
So I just want to ask because, diving, things like diving, going to the gym can be everyday activities for a lot of people, and it's really picking up it's becoming on trend, right?
Yes.
With diving and stuff like that. So should people go get themselves checked prior to, taking a diving course? Because as you said, we could be walking around with our doors open and not knowing it.
So the risk is actually quite low if
Okay.
if you don't dive very deep. So if you go deeper than say 30 meters, that's when the risk occurs. Or if you have, but some people are sensitive. So
Yeah.
at certain steps, they
Yeah.
start
Oh.
developing some symptoms. So the main thing is just be aware that certain recreational activities may put patients at slightly higher risk. So if you're doing work in a very pressurized system, for example, you're doing deep underground stuff,
Yeah.
Okay.
or diving deep, or suddenly you go a high ascent
Quickly.
Yeah.
Yeah.
Those are kind of if you have symptoms, then you
Yeah.
have to be more careful.
Oh, you travel into space because space tourism also is
Yeah,
a
yeah.
thing nowadays.
And we
So-
might see more. We might see more cases of this. But actually, you were mentioning earlier on, right? What was it? 1 in 5, 1 in 4 people
Yes.
deal with that issue where the door doesn't really close,
Yes.
right? Now, over the years, do you see more cases of this?
We actually see more cases during the COVID pandemic, actually.
Oh.
So why's that so? Because when there is this COVID infections, patients are more prone to clot formation. So they develop clots, say, in the legs, for example. And then sometimes
Yeah.
these clots, what we call economy class syndrome in the past, right?
Yeah.
These clots travel up, and then if there's a door, it tends to pop through this door and cause a stroke, you see.
Oh, right. Okay, wait, just very quickly, since we're still on the Big Show TV, we want to have a look at some of the fancy little toys that you brought in. You call them toys.
Yeah.
Tools.
Tools and toys, yeah. All right, so tell us what you're holding now.
Okay, so this is
Your camera is
Hold it
here,
up.
so
Okay.
you can hold it up.
So this is
Higher?
this is a catheter. Catheter is basically the tube that we put in through the patient's legs. If you want to close a hole, this is a catheter. This is about the size of maybe like 3 millimeters
Okay,
that we pass through a little a vein in the leg, and
Right.
this actually travels to where the hole is.
okay.
Okay, and within here there's a little cable that we can push a device, what we call the atrial septal defect
Yeah.
occluder. So if you pop this out,
Wow.
you can see
It's like
you
a
can
little
see
flower
an
that pops
umbrella
out.
comes
yeah,
out.
yeah.
And this would then be kind of in the patient's heart, right?
Okay.
And then
Okay.
when we pull this device back, it will kind of hug onto the hole. And then when we pull it, we push this out some more. Then the second disc opens.
And
So
that is
that-
what plugs the hole.
That will plug the hole. So let's just show you what actually happens, right? If I pull this back in, and we have a little door like this, and we put this tube right through the hole, right?
Yeah.
And then Tim, maybe you can help me.
And then you
so
push
I
it.
pull.
So you
I
push this cable up.
Push
And
this.
Push it out
let
just
the
gently.
flower-
Yeah. Okay, so the first disc
Okay.
opens, right?
Can you hold it higher?
Then we push this. The first disc opens. We pull it backwards, and then you push again.
I think let's
Wait.
tilt it in a
tilt it this
direction.
way.
Okay.
Tilt it this way.
Okay.
So you see the first disc,
Okay.
and then if you push out the second disc, and then you plug it, and you see from the side now you have one disc on the right side of the heart, one disc on the left side of the heart, right? Right.
Okay.
And then there's a little cable here. If you just rotate that, and this
Oh.
whole thing comes off. And
So it leaves the flower portion plugging the hole.
correct. So that actually what we actually create is we create a scaffold. The scaffold is this mesh that we put in. It's very soft.
Yeah.
And we're just waiting for the body to form.
What is it made of?
It's made of an alloy of nickel and titanium.
So it's okay to stay in there
Yes.
permanently.
So it's a bio-inert material. So
Right.
it doesn't cause any problems with the patient.
I have to say, as a car owner, right, watching you do this makes me very excited. I'm like thinking, I wonder if I can patch holes in my tires in
no.
the same way with these tools.
Oh my goodness. Okay, so let's see what other questions we have. We have actually a couple of questions on our Facebook. Eugene has asked, is it true that people with a hole in their heart have a shorter lifespan?
Okay, so it depends a lot on the size of the hole and how this hole affects the patient's blood flow. So it's a bit like what we call hemodynamics, the flow of blood within the heart chamber. A small hole usually has no impact on the patient. So they could be an athlete, there was no impact. But as the hole gets larger, then there's this abnormal flow from one side of the chamber to the other because now the two compartments now have mixture of blood. And typically one side of the heart becomes enlarged. Okay, and when it gets enlarged, then the heart is a bit like a balloon. If you stretch the heart larger and larger and larger, they can adapt for a moment. But once you stretch it out to a certain amount, it loses the elasticity, and then it becomes fatigued and weakened.
So the elasticity doesn't come back. It's like a rubber band that's been overstretched.
Kind of conceptually.
Right.
So there is actually a limit to how much it can be expanded to, and after a certain time, they develop what is called heart function dysfunction, or even heart failure. So if you stretch it out too much, then it becomes abnormal. So we actually track these patients. We see how the hole affects the heart. So if the heart becomes very large and weakened, then we know this hole really needs to be managed, needs to be closed off.
Am I right to say that, without medical intervention, the situation will never get better on its own?
Yeah.
You can't develop a hole and then naturally,
It
just starts
patches
to-
itself
exactly,
up, closes
yeah.
itself up. It will always get bigger?
It doesn't get bigger. So it actually gets, the heart gets bigger because over time, the flow
Right, yeah.
gets, is a cumulative problem
Yep,
over
yep.
time. But the hole doesn't actually get larger.
Okay.
In very rare situations, certain parts of the heart, if they develop holes, can be closed. The body actually has some ability to close it in some areas, like small kids. They have small areas that can close on its own, but those are kind of less common.
Okay, let's go back on air and with a traffic update we've got right now.
Okay.
Just gonna stand there and hear me cry. But that's alright because I love the way you lie. I love the way you lie. I love the way you lie.
Kiss 92 traffic.
All these vehicles breaking down. AYE towards MCE, 1 before Lower Delta Road exit. SLE towards BKE, another breakdown after Woodlands Avenue 2. On the TPE towards SLE, breakdown after Punggol Road. And on West Coast Highway towards the city, heavy vehicle breakdown at West Coast Highway flyover. And finally, CTE Tunnel towards the AYE, slow moving at Havelock Road exit.
It is Good Morning Dr. Day. Yes, that's right. It is back, and we have Dr. Edgar Tay, cardiologist from Mount Elizabeth Hospitals. And we're talking about living with holes in the heart and really asking the question whether they all need to be closed. Now, we covered quite a bit on the Big Show TV, so we're just going to, take it from there and talk about what kind of treatment options are available for people who are suffering from holes in the heart.
Yeah, so in the past, the only treatment available was open surgery, right? If there was a gap inside, the only way they could do it was open the chest and then sew a patch over it. And that still is being done for patients who have very large holes. But in smaller holes, we have now the option of using this, what we call a catheter-based device or tube-based device. And this allows the patients to actually have this procedure done as a single-day procedure. It takes probably about an hour and a half to close the hole.
It's like a day op. Day op. Wow.
No,
day
so the
surgery.
patient, no, they still will stay one night and
Okay.
the next day they go back, but certainly a lot less aggressive than opening the chest.
Okay.
So in some selected cases where it's suitable, this actually gives patient a lot more comfort because it's much less aggressive. In terms
Okay.
of the
And it
treatment.
doesn't leave as big a
Big
scar,
scar,
right?
yes,
Okay.
Right.
Yeah.
Okay, so I mean, if you could take us through, okay, from diagnosis all the way to the checkups, to the treatments, to the procedures itself, to how long it's actually going to take for the entire thing to be over and they're back to 100% again.
So a procedure like this, because it's minimally invasive, patients usually stay in hospital for one night and then they go back they just rest for about maybe 3 to 5 days and then they're basically back to normal.
Oh, really?
Yeah, because
Okay.
there's not much of a wound that and this basically this mesh that we put in that covers this hole will seal up, and it takes probably about 6 months for it to be completely kind of covered with
And
tissue.
it becomes part of your
Yes.
heart.
So if you were to look at it directly after about 6 months or so, all you see is a film of tissue.
Right.
Yeah.
So it can't be detected with any scans or anything like you
So
can, right?
It's because it's still metallic. So if you do a CT scan, for example, you can see a skeleton in there, but the flesh is already covered on the inside. Yeah.
So basically, I could get diagnosed today, and then I could be done with the procedure by the next week, by the following week, and then
Right.
6 months later, everything's
Yeah.
solved.
So we usually check and follow up the patients to see how the healing that occurs.
Oh, okay.
And then just make sure there's no more flow between the two chambers.
So for patients that have had their holes patched up, is there a risk of the holes opening up again or any sort of risk
Perhaps
like
they
that?
overstrain themselves. Kind of.
No, it's not
No.
likely. Yeah.
It's not
Because-
likely?
Yeah, because
Okay.
you could see the mesh is actually larger than the hole, so it really holds on quite firmly. And then once the tissue grows over it, it's like cement. So you like basically putting cement onto these concrete bars, and
Okay.
then they completely
Not
heal.
not that you should have multiple holes in
Yeah.
your heart, but is there a limit on the number of patches you can put in?
We don't usually like to patch multiple holes because then you put a lot of devices in. So if there were a lot of holes in various different parts, sometimes surgery may be a better option for these patients. Yeah.
Okay, we've got a question from Lavina, but we're going to ask it on the Big Show TV. Join us because this is really interesting stuff. The time right now is 8:22.
Kiss 92 Time Check by Pooja.
So I know you explained how holes in the heart come about, but Lavina has a question. Is it genetic?
There is some there is some hereditary component to
Okay.
this. So in general, if a mother and father doesn't have any history of congenital holes or anything like this, the chance of a baby having congenital heart disease is probably 1% or less. But if the parents have a congenital heart, like a hole in heart, then the children's risk of having a congenital hole, for example, or some form of congenital heart disease is slightly higher, maybe about 3 times higher.
Is there a way to check pre-birth?
Yes, so
There is, okay.
yes. So in the second trimester or so, usually there's something called a fetal scan that they can actually nowadays accurately scan the fetus, and they actually can look at the heart structure itself.
see.
That's so strange because
Yeah.
earlier you were mentioning that when babies are born, the hearts are like a tube, and then it starts to, and it's almost like it's because of that development of that twisting that the hole happens. But you said it can actually be spotted pre-birth.
Yeah, so the whole process of the cardiac development usually in the first towards second trimester, there was the twisting
Yeah,
occurs, and
yeah.
then the formation of the walls also then concurrently occurs.
Second
as well.
trimester.
Yeah.
Right. Okay. Wow.
Well, on this topic of technology, and of course you brought in your tools earlier on. About a month back, we were speaking to another doctor who was telling us about all the advancements in technology and all that. Now they use a lot of like robots and things like that. These processes that you mentioned today, is there a certain element of using robotics to actually conduct the process?
I think there are actually already some companies that are looking at it, doing kind of modeling on kind of early stage assessment to see whether this can be done with a robot. But generally, because it's a relatively simple procedure, it's not that complex. So it doesn't require too much technology, I think, for now. But certainly, they are looking at robots in many other areas of the cardiac treatment.
Yeah.
This particular one, there are some companies that are looking at it, but it's not kind of done routinely yet. Yeah.
So, doctor, you brought a model of a heart into the studio. Can you tell us exactly where holes are spotted?
So I'm not sure you can see this plastic model here.
If you hold it closer to your microphone,
okay,
you'll see it on the
So
screen.
if I turn this slightly, can you see the mesh inside now?
The dark spot.
Yes.
So that's roughly where the gap is.
I see.
Okay,
And it
okay.
always, and does it all tend to happen at this spot?
This is the upper chamber hole.
Right,
Okay. So
okay.
this is what we call the atrial septal defect.
Okay.
And then this model has holes in many sections as well, so you can actually spot the holes in other areas. But this would be a common location where we use this technique to close the hole.
Right. Okay.
Are there spots where this technique is not exactly the
so
best?
there are certain areas where if it's near to critical structures where say a mesh like this would interfere with internal structures, then we cannot close the hole with this technique.
With these meshes, I'm sure there's a technical medical name to these little umbrellas that you brought in. Are they used anywhere else in the body? Or is it specifically for holes in hearts?
This is specific for the holes in heart.
Okay.
Specifically for
So
that,
nowhere else does
Correct.
it? Okay.
Yeah.
Okay. Case study. Can you share with us maybe a memorable story from one of your patients who had this condition? You guys got in, and now things are gravy.
Yeah, so I think one of the striking case that we did treat recently was a young recreational diver actually. I think he was diving somewhere in Bali or somewhere, and then when he ascended, he developed weakness on one side of the body. So after ascent, really he went to the hospital locally, and then they did a CT scan. They actually saw bubbles in the brain. So basically, his bubbles actually went across and caused a blocked artery.
Yeah.
So then he came to Singapore, and then we.
This was because he was surfacing too quickly,
Yes,
is it?
possibly.
Right. Okay.
Yeah, and then we looked at he had a very large gap in the heart, and that actually allowed us to then tell him that the probable cause was from this gap, and so we went ahead to close the hole.
So it was that open door, or was it a hole?
It was due to the open door.
The open door.
Open
okay.
door, yeah. And but this particular open door was very, very open.
Open, right,
So if you
okay.
open the door so much, it almost becomes like a hole.
Right. Yeah.
And so we closed it, and then fortunately the patient's symptoms improved, recovered, and then went back home. So I think it's very important. I think for
Did he go back diving again?
Yes.
I mean, this is what
Yes.
caused
Oh,
the whole
he
thing,
did.
Yes,
right?
precisely. So he wanted to go back. Divers are quite a unique group of people.
Yeah.
They just want to go back.
So that's my question. You see, I'm thinking of taking my certified course, PADI course.
Yes.
Now I'm scared because I mean, do I need to go for a check first? I want to check if I have a door or if I have a hole, and I want to know I have zero to no risk in that department.
So like 1 in 4 people have this gap.
Yeah, that's
right?
why you're saying.
And you can't be closing doors and everyone, and
Yep.
it's already not necessary because for recreational diving you don't go so deep and you have the proper way of ascending at a certain time frame intervals and the proper training. Then that risk is not very high.
But should I go checked?
I don't think you need to routinely
need.
worry too
Okay.
much. But if there are symptoms, like for example, you get a lot of pain, you have dizziness, you have very severe headaches or weakness,
Okay.
then I think do something called a transcranial Doppler, and we can pick that up.
Okay, hang on a second. We'll go back on air with a traffic update.
Kiss 92 traffic.
Farrer Road towards Queensway, heavy traffic between the PIE and Farrer Flyover. On the ECP towards the city, heavy traffic between East Coast Park Car Park F3 and Fort Road. On the PIE towards Tuas, heavy traffic at the AYE exit. And in the CTE tunnel towards AYE, also slowdowns at Outram Road.
It is Good Morning Dr. Day with Dr. Edgar Tay, Mount Elizabeth Hospitals. He is a cardiologist. You know, doctor, you haven't even left yet. We haven't even said goodbye. And we already have viewers that want you to come back because we have viewers that want you to talk about heart murmurs as well as lipid levels in the heart. But right now, specifically, we're talking about plugging holes in hearts. Yeah. I mean, I'm sure we'll welcome you back again because there's so much of the heart to talk about. Like, if you could go on and on, you know, what are the other issues about the heart that you would like to touch on?
I think one of the things that we didn't really talk about was how do we pick up these, how do we know whether these patients have holes or not? Okay, one of the tests that we usually do is something called a bubble test. And the bubble test basically is like putting out a sauna, kind of a sauna detector on your scalp.
Yeah.
And we inject small little amounts of bubbles into your hand, into the vein, and we actually
So the
listen.
blood flow.
Yeah. So if there is a gap, right, we actually can hear these bubbles going up into the brain, and you can hear ping, 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 like a sonar. So basically, then you know that there's a gap.
Is that safe? Because I thought we don't
It's
want
safe.
bubbles in our
Of
bloodstream.
course, we don't push in a lot of bubbles.
Right,
There is a
okay.
certain amount of safety that we need to make sure that you don't put in large amounts, but it's a safe amount.
I'm so scared right now.
And
by the
I feel
thought
like
of this.
I feel like the test is scarier than the actual
Right? I'm like,
procedure
what?
to fix it.
What if a bubble stays in my brain? You know?
So the bubbles usually, because it's very small,
Tiny.
and
Yeah,
it will usually break. It will usually
Dissipate,
break, and then
right,
it
yeah.
doesn't have a permanent block unless the bubble's very large. So
And-
if you put in a super large
Large.
amount,
Yes.
of course you
Let's
can cause
not
real
do that.
problem. Yeah.
And what kind of sound do you want? Because you said this is a sonar test, right?
Yes. So normally it's complete silence, right?
Oh.
Because if you have proper compartmentalization, you hear complete silence.
But if
There's
you
nothing.
hear,
You say pop, 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 pop. Yeah.
Oh my gosh,
Yeah.
it's not a laughing matter.
If you the patients themselves know.
Yeah.
Yeah.
Suddenly it's quiet and you pop, 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 pop. You can hear the things go through.
Oh my gosh.
Yeah.
Okay, so you
Yeah.
don't want any sound in your head. Okay, thank
Correct.
you very much, doctor. I mean, we really wish we could keep you for longer, but if there is anything that you want anyone listening in to take away from this morning's session, what would it be?
I think listen to your symptoms. If you are doing, say, very heavy, you do diving, or you're doing very heavy weightlifting, and you have sudden symptoms of weakness, usually patients go to see their neurologist, and usually we work very closely with them. If there is any signs of stroke-like symptoms and you're concerned about, then sometimes we actually look for these holes.
Okay,
Yeah.
that's good to know.
Yeah.
Thank you very much, doctor. That was Dr. Edgar Tay, cardiologist, Mount Elizabeth Hospitals on Good Morning Doctor.
You've been listening